And now we will move on to our main presenter, Dr. Kim Smith-Whitley, who we are thrilled to have presenting today. She is the director of the Comprehensive Sickle Cell Center at the Children's Hospital of Philadelphia, where she is also the clinical director of the Division of Hematology. In addition, she's also an associate professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. She also holds the Elias Schwartz, MD, Endowed Chair in Hematology. Her clinical and research focus is on sickle cell survivorship, predicting and preventing long-term chronic and life-threatening complications of the disease. She has initiated 2 innovative programs at CHOP, a short-stay hematology acute care unit, and the Blue Tie Tag program to recruit blood donors for pediatric transfusions. In 2015, Dr. Smith-Whitley was a co-principal investigator of the Health Resources and Services Administration, or HRSA, funded grant focused on sickle cell disease newborn screening follow-up programs. She's a past chief medical officer for the Sickle Cell Disease Association of America. She received a Master of Clinical Epidemiology and Biostatistics at the University of Pennsylvania, and then received her medical degree from the George Washington University School of Medicine.
Thank you, everyone, and particularly to the organizers for inviting me to present on transition. I'm very honored to have funding from PCORI to look at pediatric to adult-focused transition for children, young adults with sickle cell disease. And I'm focusing that research on comparing enhanced usual care to community health workers and to a mobile app. And I will talk about that in detail, but I thought that I really needed to put that program in context as what we're doing pragmatically here at CHOP in order to foster successful transitions. So with that, I'm going to go to the next slide and just disclose that I do participate in advisory boards for new stakeholders in the sickle cell space, pharma, as we have new targeted therapies being developed for sickle cell disease. Next slide. I don't need to really belabor the objectives, but I want to go through and present challenges related to transition, and then I want to present solutions. One solution may be the way that we have decided to approach transition at Children's Hospital of Philadelphia, and I will talk about that in more detail, but then present an outline of our PCORI-sponsored work, which we are still trying to get full IRB approval and getting up and running and into recruitment mode. So I will be giving you a very brief overview of that project. Next slide. I don't really need to tell this audience that sickle cell disease is a complex chronic illness in which people with sickle cell require comprehensive care across the lifespan. And really this is a joint effort between families, patients, providers, and the health system for clinical care models across the lifespan in the pediatric and an adult setting. I don't think that many of us could do what we do without some community-based organization support. A lot of the exposure that I've had through the Sickle Cell Disease Association of America does not stop there. We have many entities involved in the community with sickle cell initiatives. So I think that we are in a very unique time where we have community-based organizations that are becoming more resourced to work with health systems as well as with patients and families to get children living with sickle cell disease from pediatric to adult-focused care, as well as to get them ready for success in life as they go from high school to either college or work. And then we have multiple federal agencies that are involved in the sickle cell space, including now pharma that is involved with sickle cell by providing research on new targeted therapies. And really, if we are successful in what we're doing, we will bring all these stakeholders into the transition space, because this is a unique issue for sickle cell disease. And I'll talk about why, and why we really need a village to get those individuals with sickle cell across the gap that is transition. Next slide. Sickle cell disease has really, I believe, transformed from a disease of childhood to a lifelong chronic condition. We have not met the mark successfully with improving survival in the U.S. as we have seen in the UK, but we are getting closer to understanding what is necessary to keep individuals living with sickle cell disease healthy. The approach to pediatric care has transformed from being a reactive approach to a proactive. And what do I mean by that? Well, about 30 or 40 years ago, we were responding to sickle cell complications after they occurred, actually telling families that their child had sickle cell disease at the same time that we were telling them that they had a complication of sickle cell disease, such as overwhelming life-threatening sepsis or painful episodes. And really, with the advances with penicillin and infection prophylaxis, we had a justification for nationwide newborn screening. And now we have really tried to focus on preventing complications before they occur. And that's going through early diagnosis in the newborn period, getting them on infection prophylaxis, putting them in comprehensive care programs, focusing on long-term therapies that can prevent a recurrent acute pain and acute chest syndrome. Really early recognition of acute problems once they occur, and aggressive treatment. Particularly, we've seen that bar change with acute chest syndrome, and then using transfusion therapy when necessary for primary and secondary stroke prevention. And now we're starting to really focus on screening for chronic in-organ damage across the lifespan for individuals living with sickle cell disease. So really going from this more passive, let's not do anything until there's a big problem, to really trying to prevent problems before they occur. Next slide. Charles Quinn really had a nice study that was published in 2004, where he looked at a cohort of children who were followed at the program in Texas, and look to see what the lifespan was for that new cohort of patients that had really been more in the 80s and 90s. And what he found was that of children born over the last 20 years, he saw 93% will survive till 18 years of age. And comparatively, it was more closer to 40% in the 60s. Next slide. So we had a population that was able to survive many of the pediatric complications, now going on to adult-focused care. And we had a lot of good things that were happening in the sickle cell community in the pediatric world, but we were still having continued morbidity and mortality, particularly in adult-focused care programs. We had no universal cure. We had few disease-modifying therapies, and that was impacting not only the pediatric but the adult. And then we had poor access to high-quality care across the lifespan. We needed to improve existing clinical protocols. We needed to learn how to track clinical outcomes better, which you all are doing very well through your programs, but we really have still not set the bar appropriately nationwide. We really don't have good markers for care utilization and cost. And then, of course, just as we have advocated for improving resources and clinical research to support pediatric care, we really need to increase resources to support adult-focused care models. We have clinicians that have been in this space for a long time that have been not as fortunate to have as many resources available to them as we do in the pediatric model. Next slide. One of the other things that still makes it difficult for individuals living with sickle cell disease is, as you go across the lifespan, the complications tend to increase. And one of those complications that characterizes sickle cell disease is acute pain and as well as chronic pain. And as we know, we still don't have really good methods of assessing pain and communicating about pain to patients. This is Nazir's image called 10 Redefined, as he describes what it's like to be asked on a scale of 1 to 10, for him to rate his pain intensity. And then we really haven't looked at the burden of sickle cell disease across the lifespan as it addresses acute and chronic pain, utilization of resources, and the challenges related to opioid prescription tracking remain. We are still treating acute pain the same way that we were 40 years ago, which is supportive care, and we really don't have disease-modifying therapy to address the acute pain episode. Next slide. The other thing Ophelia Alvarez showed in this 2013 publication is even though we were improving morbidity and mortality in the pediatric age group, next slide, you can see that we were still struggling in the young adult age group. After age 19, mortality increased from 0.6 to 1.4 in the years that we were going through this very nice period of infection prevention, utilization of penicillin, appropriate vaccinations with pneumococcal vaccines. And yet we still were not moving the bar for survival in this very vulnerable age group between 20 and 24 years of age. We have seen improvements in survival in UK populations, and part of that may be access to care. And hopefully when groups like yours collect information, we'll start to see, hopefully, the bar move for mortality in the age group and improvements in survival, but we're just not there yet. Next slide. We've had incredible advocacy for sickle cell disease care and research. I think many of you are probably already aware that the Treatment Act was just reauthorized yesterday. It still has to go through a little bit more, but we have really had good advocacy for programs to serve the sickle cell population. We've had great advances in infection prevention, stroke prevention, some disease-modifying therapies with hydroxyurea therapy, and more recently, L-glutamine. We have a cure for sickle cell disease and stem cell transplant, but you have to have a sibling that does not have sickle cell disease that's a perfect match, and that's a rare thing to find. So we've had some advances in care across the lifespan that they really have mainly impacted the pediatric age group, I think even more so than the adult population. Next slide. However, as we have made these advances, we've also increased the intensity for outpatient visits for individuals living with sickle cell disease. You know, we ask our patients to come to clinic 3 to 4 times a year for routine visits to track possible end organ damage and to monitor therapies such as hydroxyurea. We ask them to come to primary care visits. We have them come to ancillary studies, TCDs, MRIs, echoes. We bring them in sometimes for special shots, special dental visits, all of the things that we do with long-term therapies, and that does not address the urgent care needs that they have for febrile illness and pain episodes. So we're really increasing the burden on the patient and family across the lifespan as we've advanced in technologies to identify complications before they occur, identify high-risk populations, and then institute long-term therapies. Next slide. So we really wanted to address a model that incorporated the community-based organizations. We understand that one of the things that is very much so needed in the sickle cell population is any chronically ill population is to focus on academic and vocational goals for the families. And really, with all of the care coordination that's needed, all of the stresses put on the family, we really need a community-based component to help be a resource to facilitate getting to appointments, obtaining IEPs and things like that for school, and help with navigation of the healthcare system. So we've really developed a multidisciplinary approach. We have integrated behavioral health in clinic because we understand that psychosocial support is needed in every healthcare setting, whether emergent, urgent, or acute, for individuals with chronic illnesses, including sickle cell disease. Next slide. We have a team that is pretty broad, and what we have done is we were a team of 4 about 15 years ago, and we've grown. And one of the ways that we have grown is by advocating for increased resources by keeping track of our data and expanding on our team as needs arise. And so many of the team members supported on this slide are not supported through funds by the division, but through third-party payers, many of them insurance companies who are supporting our behavioral health workers, our community health workers. And I think that that just shows how getting multiple stakeholders involved in the clinical goals of your program really let you bring in new resources. And this is something that we're trying to institute in the PEN program, which is a new adult-focused program in our community. Next slide. So what does this whole infrastructure and healthcare system environment mean for individuals with sickle cell disease? Well, it means that we have more children who are surviving to 20 years of age, so more children who are transitioning, more children who need to get through the education system, graduate from high school and go on to college or go on to a vocation. We know that there's a period of vulnerability for with increase in complications, increase in mortality. We know that their cost of care is high and the barriers are high in this population in general, and that the patient population sometimes is stigmatized by encounters with the healthcare system around pain management and opioid use. We also know that pediatric population is increasing in the need for outpatient services, and we hope that that's also translating to adult-focused care as well, as we screen more for high-risk features of sickle cell disease, instituting therapies before the disease progresses, and then hopefully long-term preventing in-organ damage. And that really takes a multidisciplinary, comprehensive approach. Next slide. So is this different for sickle cell than it is for any other entity or chronic illness population? And the next slide really talks about, I think, one of the things that identifies individuals with sickle cell disease as being a little bit different. My approach when I'm talking about transition, of course, is the provider perspective, but you know the patient perspective is equally, if not more important. And what we hear from young people as they go through this transition period is that they feel isolated, they feel that they have been, quote unquote, kicked out of programs, that they're ill prepared for the transition process. We know that healthcare systems are not always as supportive of adult-focused care programs or sickle cell programs at all, in the sense that they are a population that has high cost. They are a population that has high readmission rates, appropriately so, by the way, in many circumstances, but that's looked upon negatively by healthcare systems. And we know that they are looked at as a population that is very much so characterized by acute and chronic pain, and that increased hospitalization rates, increased length of stay, and high cost of care. So this is a population of individuals with a chronic illness that is not only dependent on the outpatient setting for care, but also for the acute care setting to manage painful episodes. So it makes them often need to be reliant on emergency departments, no matter how good their outpatient care, as well as their inpatient stays for pain management and other complication management. Next slide. So this is another depiction by Blinder et al. And that gray area just shows you that emerging adult between 16 and 22 years of age period. And that blue hashtag line demonstrates transfusion therapy. The gray hashtag line demonstrates hydroxyurea therapy. And as you can imagine, you're seeing those hashtag lines start to decrease as the population ages across the x-axis. And as these solid lines demonstrate, the red line shows the increase in complications over time, and those are subdivided into various systems, but you get the message that just as individuals are starting to see more complications, sometimes their access to long-term therapies decrease. I want to point out also by saying that, especially to my adult care providers on this call, is that this is not a statement or a criticism of the care provided in adult-focused centers. I think that the care is excellent. I think that we, at least at our hospital, start to see challenges emerge in the teenage age groups. Trying to keep patients engaged in clinic, particularly in the early to mid-teen years, is quite a challenge. So I just want to point out that I think that this trend is happening before they actually get into adult-focused care programs. Next slide. So I've talked about how hydroxyurea, we know it's a disease-modifying agent, and on the next slide, you can see that it's associated with decreased pain episodes. Transfusion therapy is needed primarily for primary and secondary stroke prevention. We try to get many individuals who have abnormal TCDs onto hydroxyurea therapy, but sometimes those patients are not appropriate for that. And we know that as this population ages, they're going to need to be on long-term therapies for stroke prevention, whether or not it's hydroxyurea or transfusion, and that really puts a new weight on managing hydroxyurea therapy. And of course, as we use hydroxyurea more and more, I have data that looks at my less than 5-year-olds who are eligible for hydroxyurea, and 78% are now receiving hydroxyurea therapy, compared to 35% who are eligible in the 18 and over age group. And I think that that message really needs to be taken, as one of the issues could be that if you start individuals on long-term therapies at younger ages, then hopefully they'll have a higher likelihood of continuing those long-term therapies across the lifespan. And because hydroxyurea was introduced late to my young adult population, I think that that's why the uptake is so low. Next slide. So I think that the other thing that I just want to reiterate is the individuals living with sickle cell disease, as this third statement or the third bullet would have stated, also come from homes that sometimes are poorly resourced. So we have situations where the resources to manage all of the complexities of care, with care coordination, with a navigation of health systems, those resources sometimes are not in the home, and we have to find other sources to support children through early childhood and across the transition age group. Next slide. And of course, one of the things that we're finding is the obvious, that pediatric resources do not equal adult resources. That because sickle cell disease was looked at as a pediatric disease in the past, a lot of the resources within the sickle cell community are in the pediatric care centers. And we really need to advocate for similar resources being in the adult-focused care areas as well. You know, when you come to see pediatric sickle cell expert, you're often going to be seen by a nurse practitioner, a behavioral health specialist, a social worker, maybe even an education specialist, a neuropsychologist. And that team is not necessarily duplicated in the adult care setting. And I think we really need to advocate for resources across the lifespan. And really what I'm hoping to show in the next few slides is really kind of how we started to try to do that in the Philadelphia area, and making sure that individuals are transitioning to like programs as they cross from pediatric to adult focused care. Next slide. So I really want to reiterate that it does really take a village. And I know I'm really fortunate here at CHOP to have that village, but one of the key pieces that is critical to my team is having an ED champion. And really, if in a situation like sickle cell disease, we're so reliant on acute care settings in order to manage pain and febrile illness. You really need to have somebody in the emergency department who can be an advocate for patients with sickle cell disease. We have an inpatient nurse liaison as well that communicates with the outpatient team on all of the inpatients with sickle cell disease, and I think that that's really important. And then multidisciplinary teams. That's going to be a challenge as individuals transition from pediatric to adult-focused care as well. If you have a child with sickle cell disease who had a stroke at age 2, who's been followed by a neurology and the stroke team all of their lives, we have to find a way for them to get that neurologic subspecialty care on the adult side as well. And then I think that everybody understands that the other subspecialists are very, very vital, ophthalmology, orthopedics, in finding similar resources in the adult care setting as we do in the pediatric care setting as well. Next slide. So this is one of my last challenges slide, but I really want to reiterate that we have to work on developing resources on the adult care side, making sure that there's multidisciplinary care, really trying to focus on not only transitioning from clinic to clinic, but from ED to ED, from inpatient setting to inpatient setting, because these are the challenges of the individual living with sickle cell disease. It's one thing to say you're going to go see Dr. Smith-Whitley, who's going to provide your adult care, and then get to that setting and then find that there is not a protocol in place for pain management in the ED, or that there is not the erythrocytophoresis program that you need. So that there are many aspects of care that need to be addressed in the transition period. And then, of course, really understanding that chronic pain develops across this time period as well, and advocating for individuals with sickle cell disease to get appropriate care, not only in the pediatric but the adult side for chronic pain syndromes. Next slide. So what is the classic definition of transition? I think many of people on the phone know the Society for Adolescent Medicine's definition of purposeful, planned, and timely movement from child to family-centered pediatric healthcare to patient-centered, adult-oriented healthcare. But I think that the AHRQ definition that really incorporates transition characterized by also changes in culture, changes in values, shared ideas, behavioral norms. And that this is really something that if we do not address in the transition process, we're really doing our patients, our adolescents and young adults a disservice. Sometimes we know that there is a change in culture for pain management. There might be a change in culture for the inpatient stay and how acute chest is prevented. And so we really have to prepare individuals living with sickle cell disease to be prepared for a new setting of care that may be cultural as well as clinical in nature. Next slide. So what makes transition successful in the general population with chronic illness? And you can see that these are the things that tend to make individuals successful, coming from homes that are highly resourced with incomes 100% above the poverty line and being privately insured. And that's not the general nature of the population that we serve with sickle cell disease. Next slide. We, again, know that single provider-driven with limited resources is going to be a challenge, that institutional experience with sickle cell in different adult-focused care centers may be based on a small population of patients with high utilization of emergency and inpatient care, and that does not reflect the entire sickle cell population. The other thing that we know is that we really do not communicate well, either within a center like mine, we could do better about transition, or between a pediatric and adult-focused centers about the needs of individuals with sickle cell disease as they go through the transition process. Next slide. And you can go to the next slide. So one of the solutions on the next slide is the AAP GOT transition model. And I'm going to go through the solutions that we have kind of adopted at Children's Hospital of Philadelphia to help with transition readiness, to help us understand what we need to do to track and monitor the transition process, and then what we need to do after the transfer has occurred to ensure that the individual with sickle cell disease has been seen by the adult focused care team. And as I go through talking about the different aspects of GOT transition, I want to say, and it will be a link on the next slide, that the AAP's GOT transition program has a link and has multiple resources. And the resources on that website do not only address the provider side, but also the patient side. There are videos that are available for patients to look at while they're in clinic or while they're at home that explain the difficulties of the transition process. There are videos embedded on that website that talk about, from a patient perspective, what a successful transition is. They have multiple checklists on how to keep insurance active, what needs to be like an information set that individuals should have with them as they go to the adult care system. So I'm not going to go through all the resources involved in the GOT transition program, but I will give you the link to that website, and it is really an excellent resource. So in the GOT transition process, it really talks about how you need to address establishing access to providers who are experts in the care of adults with sickle cell disease early as you plan your transition program. Establish a skill set on disease self-management and health system navigation that patients need to complete through the process. Adopt a tool that assesses somebody's readiness for transition. One of the things that I think is unfortunate is that we also often use an age cutoff for when we think transition needs to occur. Or unfortunately, when young women become pregnant, we then have a transfer instead of a transition, as they can no longer be provided care in many pediatric centers. So I think that assessing readiness across the transition period is very, very useful. Developing objective markers of what a successful transition is, and I'll talk about that in detail later. Innovative methods to improve communication between practitioners in the pediatric and adult care settings. They talk about that and how to develop different models, and there's resources on the website that help you do that. And then allowing opportunities for adolescents and young adults to interact with the adult care team is something that the GOT transition program actually recommends. On the next slide, you see the link to the GOT transition website. The 6 core elements of the program is developing a transition policy, developing a system that allows you to track and monitor the transition process, frequent assessment of transition readiness, developing a transition care that includes the patient and their family, developing a transfer of care kit, which usually includes a letter that summarizes the individual's medical care, and then assessing transfer completion. And the GOT transition website recommends that the pediatric institution contacts the adult focused care provider within 1 to 3 months to make sure that the individual who has transitioned has actually been seen by the adult care team and that care is in place. Again, I said that there were resources for patients and providers, but also for policymakers on their website. And there are some very nice transition readiness tools that have been adopted for sickle cell disease by the American Society of Hematology. And I've given you that link. The track tool has become a little bit sickle cell specific in language. And then there's also a sickle cell transfer summary that has been adopted, and that's available through those links too. Next slide. This just gives you an overview of the GOT transition website, all of the resources, and I can say that these are ever changing. Every time that I go on there, there seems to be a new video or a new link to another website that can improve a community-based organization's ability to participate in this process, how to reach out to community-based organizations in order to get help through the transition process. I think these are really nice tools that are now embedded in the website. The next one goes through, the next slide shows you the 6 core elements. And one of the things I just wanted to say is they have a recommended transition timeline. Everybody always struggles with when's the best time to introduce transition, the concept of transition to individuals living with sickle cell disease and other chronic illnesses, and the AEP recommends age 12. I have talked to different clinical centers and community-based organizations that actually introduce transition at the time that they transition them into their centers. And one of the ways that we talk about transition here at CHOP is even in the newborn period, when they come in for their first visit, we talk about that we will be successful if we're sitting here anywhere 18 to 21 years later, where we are actually talking about that young adult going on to a team of healthcare providers that will help them throughout the rest of their lifespan. So really kind of like engendering that hope right in the first visit, and then continually, like annually, reminding families that the transition process is coming up. We start our transition policy administration really starting at age 12, but then we also try to introduce between age 12 and 14 the patient having some quote-unquote alone time with the physician and the team in the room. That is sometimes very well adopted, but by 18 years of age, we really very, very strongly encourage that and advocate with all of our providers to really focus on addressing the young adult in the room as the primary person who will be responsible for their care. And then by 22 to 23 years of age, really looking at the end of the transition process. And you can go on to the next slide. That just gives you a little example of the template for the transition readiness tool and the clinical summary that have been adopted by ASH and that are sickle cell specific on the website. And you can go to the next slide. So what have we found to be successful in our program? Well, one, the GOT transition. I think also adopting the philosophy of transition squared. And HRSA has really nicely stated that we should not just be focused on transition across the healthcare system, but transition from school, high school, to either a vocation or to college or another higher education of learning for individuals with sickle cell disease. So not just focusing on getting them from pediatric to adult-focused care, but really focusing on getting them to, I'm sorry, I just lost my screen for a second, but also really focusing on getting them successful in life. We really try to utilize a community-based organization system in our program as well, because I think that by involving a community-based organization in this program where they do not have to deal with transition, they have to look at consumer engagement and maintenance of consumer engagement, but really trying to get them involved in the process has been successful for us. Good preparation, I think, is really key. Disease self-management, starting really early at 12 years of age and even sometimes younger. Do you know what type of sickle cell disease you have? Do you know what hemoglobin is? And do you know what your steady state is? Do you know your medications and why you take your medications? So disease self-management, sickle cell knowledge, health system navigation are important aspects and skills development that needs to occur for, I think, before a successful transition. Also establishing realistic expectations about the process with all participants. And this is really where I do outreach to the adult-focused care centers too, so that I can talk about the population that they will be receiving, and really the issues around sickle cell centers that are located in academic medical programs where there's a lot of clinical research, there's a lot of engagement of different subspecialists, then I think that this becomes a real issue, is how to transition all of those different aspects of care for that individual living with sickle cell disease, and establishing realistic expectations about when it's going to happen, why it needs to happen, and then what the services that they're going to receive on the adult care side needs to be clearly stated up front. Also, providing support through the transition process. Some programs, as you we'll hear about later, have already incorporated community health workers in the transition process. Some people, in Dr. Asunklu has a PCORI sponsored project where she's going to be using peers to mentor individuals with sickle cell disease through the process. Also using community-based organizations, and some programs have adopted a nurse practitioner that specifically addresses the young adult population, so that they become, that nurse practitioner becomes their provider before they transition in the pediatric side, and then that provider, that nurse practitioner, actually goes to the adult side and becomes their provider on the adult side. That's a unique situation that can only occur where the pediatric and adult focused programs are in the same healthcare system, but we see that in cancer survivorship, and other models are starting to emerge in the sickle cell community as well. Next slide. The other thing is really giving the adolescent young adult an opportunity to practice transition, and it really helps with autonomy. And one of the things that we try to do in our program is transition from their primary care provider, from a pediatrician to an internist first, before they transition their sickle cell care. We will also try to use other subspecialty care, for example, using transition for a patient with sickle cell disease and asthma, do the asthma transition care before using the sickle cell, so that the young adult has a chance to practice those unique skills to be successful while they are still within the pediatric sickle cell program, and then letting them transition their sickle cell care later. Also allowing previews of the adult care setting. Dr. Miriam in Connecticut has a very nice program where she actually goes to the pediatric setting and participates in the care of the pediatric side for like one conference before that young adult transitions over. Some people have done this virtually through telemedicine, and the adult program dialing into the pediatric visit and participating in the care in the pediatric clinic before the individual comes over. That whole concept of previewing can also come through touring the facilities. We have heard of sickle cell transition camps and community-based organizations where they take young adults, adolescents and young adults, to the different adult programs, let them actually hear from the providers in their programs what to expect, and tour the facility so that they can then select the adult program that they're interested in attending. The other thing is that we have used the first visit with the adult program sometimes as a consult. This is very insurance specific, but we can let them go, trial the adult program, come back to the pediatric center one last time to tuck in any loose ends, and then go back to the adult program as a true transfer of care after they've had that first initial visit as a consult. And I really think that transitioning other primary care and subspecialty services to that healthcare system before the sickle cell care is another way to preview the adult care setting. The other thing that I think is incredibly important is having a good transfer letter, really talking about what the challenges are for that individual living with sickle cell disease as it relates to maybe even long-term medications such as hydroxyurea adherence, what the challenges have been about toxicity to some of these medicines. All of those things need to go into that letter. The importance of including red cell alloimmunization and issues with delayed hemolytic transfusion reactions are key. Making sure that the insurance is appropriate for the adult care setting. Sometimes the insurance that is par with different organizations changes over time. So really having that all of these things worked out so that there is the best chance for a successful transition is really appropriate. One of the things that we try to do here is actually have the young adults start making their own pediatric appointments first, so they're answering the question on the phone from the intake person about what insurance they have, so that when they're doing that on the adult side, they're familiar with that. Calling, getting their prescriptions refilled, all of these things that build skills are really important to incorporate in the transition readiness process. And then really is reassessing your own program's performance. One of the reasons that we really wanted to take on transition here is we thought we were doing a great job. We've had a transition program in place probably for about 20 years, and yet we went to one of our adult programs well into the process about 15 years ago, and found that about a third of our patients were not surviving 10 years after transition. So what are we doing differently? What do we need to do to make sure that we're delivering a healthier adult who's embedded in the system, who can be successful within that program to the adult care center? So really trying to reassess what we're doing for long-term clinical outcomes, but also patient satisfaction with the process. Are they happy with how we're preparing them? Do they think that there are things that we could do differently? What about the sense of isolation? Have we done anything to decrease that? And then really, what are we focusing on and improving for the next cycle as incorporating the feedback from the patient and the families? That needs constant reevaluation and reassessment. Next slide. And then really advocating for increased resources throughout the system, particularly on the adult side. You really need to know your numbers. And the next slide really talks about how we track the number of kids that are coming through our emerging adult program. We have at least twice yearly meetings with the other pediatric program in town and our 3 to 4 adult care programs, where we're talking about what the needs are of the patient population, the numbers that are expected to transition in the next year. This has really enabled us to also bring in third-party payers to advocate for either a community health worker or a behavioral health specialist or provider on the adult side to be there to receive this complex young adult. I think the other thing that's important is to really look at the numbers of individuals who are coming in with pain. And one of the things that I try to reiterate with our adult healthcare systems is that the face of the sickle cell population is changing. I really think that we, by starting disease modifying therapies early in the course, have really changed the way that individuals are managing their pain, the frequency of their pain. And I like to go to the healthcare administrators and talk about sickle cell disease and the changing face of sickle cell disease so that they know what to expect and to know what kind of resources need to be in place to receive them. So you can go to the next slide and then the next slide. And really, again, the multidisciplinary team with an integrated behavioral health specialist, really having an education specialist that can help us help the individual with sickle cell disease achieve academic as well as vocational goals is really important, and having that community-based component, often in the forms of camps, in the forms of transportation, in the form of care coordination, in the form of support groups, is really important throughout the lifespan. Next slide. One of the things that we have been able to incorporate in our model is tracking of the transition process through our electronic health record. And that really is an important way to understand what aspect has been achieved. If the individual has received a copy of the transition policy, if they are starting to come back in the rooms with the primary sickle cell provider alone, if they are starting to make appointments on their own, and that needs to be tracked just as well as all of the other things that we track in our system regarding immunizations, PCD screening, hydroxyurea, and that's really been incorporated into our care model. Next slide. We've also realized what sets individuals up for failure. And one of the things that I think that we see in the pediatric world is we start to see, particularly at high school age, individuals start to drop out of clinic attendance. It is a red flag, and it's very important to keep individuals engaged in care throughout high school so that they're not showing up at age 21 to our emergency department with pain, not having been seen by a sickle cell provider for the last 4 years. Also making sure that social supports are in place. Individuals who have not had a adult or a parent involved in their care for social support throughout the high school years, really trying to find another resource for them in their communities to be supported through the transition process. I think the more complex, the more comorbidities an individual has, the more problematic the transition process is. If somebody has a behavioral health issue, such as depression or bipolar disorder, it becomes more of a difficult transition. If they've had disruptive behavior in the clinical setting, either leaving against medical advice or having interactions on the floor with the inpatient teams that are disruptive, that is a more challenging transition. And then in certain situations, there are individuals, in the case of pregnancy or in the case of disruptive behavior, that have been forced to transfer rather than transition. And that, I think, is a setup for a failed transition. Next slide. The other thing is not being very transparent about the differences in acute and long-term care settings. Really trying to understand what protocols are in place for pain management at other institutions so that individuals with sickle cell disease can be prepared for it. For example, as you all know, in adult emergency departments, individuals with sickle cell disease are not triaged maybe in the same way that pediatric patients are. So getting the patient ready to go to the emergency room sooner in a pain episode is something that we in certain programs counsel about if they don't have day hospital or infusion centers, so that they can navigate their acute pain episode more successfully. Also making sure that there are apheresis services, clinical research support groups, and community-based organizations on the adult care side is important to consider right from the start. The next slide, I think we've already reviewed many of the things that are our solutions to this process, and everybody has had a different approach in different systems. It's important to understand what the administrative needs of the program are, understanding what the limitations of the healthcare system are, and then designing your program to try to meet those marks. Also, I think the other thing that is obvious is, if possible, having more than one adult-focused program to go to so that the individual with sickle cell disease can choose is ideal, but not necessarily the case. And when there's only one option in town, I think a warm handoff is easier and mandatory in all situations, but very appropriate for those situations. Because you really have to make sure that that transition is going to be successful, because there are limited options. Next slide. So this is just a quick example of how we track different outcomes in our electronic medical record. And if you see that hashtag bar, that was the goal that we were trying to get. This is just an example of TCD screening. And I wanted to reiterate the importance of a medical home. And when in our healthcare system, when the medical home is a member of our healthcare system, as you click onto the next slide, you can see how now that blue line always goes above the hashtag. And those are all of our patients that have a CHOP-based PCP. And that's because we can share an electronic medical record, and they can see all of the goals of care within our system. And we really need to figure out new ways of creating these medical homes, for electronic shared data, so that we can share opportunities to meet different clinical goals. And this is what we're trying to get in our system for transition, because I think that there are many players in the transition process, the PCP, the emergency department, and sharing these goals needs to be communicated as well. Next slide. So our key features and our things for success have been exactly what I talked about: having champions, having coordinated care services available, having outcome tracking through the electronic record. We have a multidisciplinary intervention navigation team called the MINT team that helps with our transitions that are going to be difficult or that we know are going to be particularly challenging, or even those that have not been successful where the patient has come back to us having not been able to find a medical home on the adult side. And so some of these resources exist in pediatric centers and academic centers. I know that there's one at Hopkins. And so sometimes and bringing in these teams for difficult cases is really necessary. Next slide. The other aspect that I want to mention is that having an advisory group of young adults that participates in how we need to change our transition program has been really, really important. We have, as I said, these meetings with the community-based organization, the adult-focused care teams, and pediatrics. And having young adults that can participate in that process, I think, is very important to meeting improvements that need to be done and increasing patient satisfaction with the process as your program matures. Next slide. Next slide. So based on this, we wanted to look at ways that we could improve our transition process. And one of the things that's clear by looking at the socio-ecological model of transition readiness, this is a figure that Sophie Jan shared with me from her publication, is that there's some pre-existing factors that we can't modify that much, but there are modifiable factors: disease-based knowledge, skill building, self-efficacy, and education, that we can use different motifs to try to alter. And we already had at our program a successful community health worker-based system in asthma care, and we also had experience with developing a mobile health app for another chronically ill population. So we thought that it would be nice to look at community health workers and mobile health apps and how we could incorporate them into the modifiable variables so that we could improve, hopefully, our transition process. And the next slide is a figure by an article by Louis Su, where he did a environmental scan to see where community health workers were being utilized in the sickle cell space, and how community health workers, through having 7 core roles, and that's the little bar, the little list on the right-hand side: cultural mediation skills, informal counseling and social support, providing culturally appropriate health education, particularly health education as it relates to hydroxyurea adherence has been, community health workers have been involved in that, advocating for individual and community needs, assuring that people get the services they need long-term by following up by phone or in person, building individual and community capacity, and providing direct services are all the things that community health workers have brought to the table, either those that are housed in the hospital side or those that are housed in the community-based side. And I think that trying to incorporate community health workers into the transition process is something that could help with disease education, disease self-management, health system navigation, skill set development, and using that along with the next slide, a mobile app could actually foster knowledge for sickle cell disease and actually provide a tool with which adolescents and young adults could interact with. We know that certain one size is not going to fit all. Certain adolescents, if they're more introverted, may respond more to a mobile app than those than responding to a community health worker. But knowing that the African American population seems to be very adept at using mobile health technology, then using an app for sickle cell transition might be successful. Next slide. And then there is really a nice demonstration about an app used for those with IBD, inflammatory bowel disease, called the Inside Track. Has really been quite successful. And Lori Crosby is the designer of a sickle cell specific app, and she is a member of our PCORI team. And so we thought that utilizing Dr. Crosby's app to improve transitions of care from a pediatric to adult focused care might be of benefit to the sickle cell community. So the next slide demonstrates that we just were able to obtain PCORI funding, and it's supporting our COMETS trial, the management of care transitions for emerging adults with sickle cell disease. I have co-PIs, next slide, as a part of the process, and we're participating with Cincinnati, Connecticut, St. Chris, which is right across town, and Cohen's and Northwell. And this just shows Dave Rubin and Sophie Jan, who are my co-PIs on this project. The next slide talks about the study purpose. We're going to compare the effectiveness of these two interventions, either using a community health worker or using an mHealth app versus enhanced usual care, and really to see whether or not we improve health-related quality of life, transition readiness, and acute care utilization in adolescents and young adults with sickle cell disease. The next one shows our study aims. We also are going to try to see if we can keep patients engaged. We'll have markers of individual and family factors that may be moderating our intervention or treatment effects, and explore the association of enhancements to usual care on pediatric and adult care utilization. Next slide. The study population is anybody who is ready for transition within the next 12 months, and those individuals who cannot interact with an app due to any intellectual disability would not be included in the study population. The next slide just talks about our enhanced usual care. We have spent the last 12 months developing checklists agreed upon by both the pediatric and the adult providers as what elements need to be taught in order to prepare an individual for transition. The next slide talks about the components of what the community health workers have been doing, and they've been going through different curriculum to try to get ready to guide individuals through the process. So we have a core curriculum, we have supervision for the community health workers on the hospital-based side, and then they're going to be tailored support on how they're going to interact with individuals during visits or during telephone follow-up calls. The next slide talks about the components of the mobile app that Dr. Crosby has developed. And the next slide talks about the patient-centered goals. Provision of information is going to be interactive, and text messages are going to be actually shot out to those participating with the mHealth app as they go through the transition process. They can track their symptoms on their app, and they can actually monitor their goals and whether or not they've achieved their goals. And that is something that we're pretty excited about, and that is ready to rock and roll. And we're just trying to get everybody through their informed consent process, and recruitment we're hoping will begin by the end of this month. Next slide. And you can go to the next slide. These are, on the next slide, some of the tools that we're using to measure quality of life. We're a little bit concerned about the time that it's going to take to go through these measures, but we think we've got it down to as minimum as we possibly can. We're trying to work with Dr. Asunkwu so that some of our measurement tools are similar between the two PCORI-sponsored projects, so that we can actually share data and actually measure outcomes compared to her peer mentoring program. Next slide. So in summary, transition is a difficult process in any population with chronic illness, but we know it's particularly challenging in sickle cell disease for multiple reasons. Programs that have a formal transition process, I think, can be more successful. It does not feel as though that it is personal when it is systematic. That they will understand that the individual participating in the transition process, that everyone needs to go through it, but it can be personal in how you do it successfully. And so that really supporting individuals through the process until they get to the adult provider side and after, I think is a key feature of what makes a formal transition program successful. And then really we need to increase advocacy efforts to make sure that there are resources for adult-focused care programs for individuals with sickle cell disease, so that they are really armed for success, because the care coordination, the behavioral health consultations, all of those things are in place on the adult side as well as the pediatric side. This is a list of references that I want you to have on the next slide, because you all will all get a copy of these slides. And they go through some of the overviews of community health workers and health IT systems, and the link to the AHRQ report, which really went through transitions of care with not only from pediatric to adult focus sides, but from ED to home as well, and how health information technology can be utilized there. It's a very important resource. And then on the last slide, I wanted to start the discussion, because one of the things that we all find challenging is what for you will define a successful transition, and really thinking about it for the patient, the provider, and the health system perspective. And then once you define that, what can you do to measure the success of that process? Because I think that in order to really develop a strong transition process, these are key questions that need to be answered. And with that, I'll take any questions you may have.
Thank you so much for that very comprehensive talk and really fascinating work you're doing. We already have one question that has come in. But before I say that, I just wanted to mention that the program, the Sickle Cell Data Collection Program, has made 2 videos on transition, and during the question and answer, I'll put the link up on the screen. And also that the last webinar we did was with the GOT transition team, and the recording is available for that if you want to hear a lot more detail about the GOT transition program and the resources available. But with that, I'll read the first question. You know, as a CBO, we're wondering, how did you get the numbers data for the CHOP program? We desire to get the numbers for our Nevada providers, but we want to make the process simple.
So I think that one of the things that I know that one of the ways that we got the data is through our Health and Human Services. We have a state-sponsored program for sickle cell disease, and our 3 adult provider programs and our 2 pediatric programs all participate. And so I got the data actually through that system. But when we meet regularly, twice a year, with our community-based organizations that are involved in sickle cell, as well as our adult providers and our pediatric programs, I ask the programs to all bring this information with them. So the pediatric programs give this data on a twice yearly basis to the community-based organizations in that setting. So I would recommend that maybe one of the solutions is to find a way to encourage the pediatric and adult focused programs to meet with the community-based organization to see how you could collaborate and to improve transition readiness and to be as a support system through the transition process, and for them to bring that data with them so that they can show the numbers of individuals that they are transitioning on an annual basis.
Perfect. We have a question here from Susan Palukonis, who's sitting next to me.
Hi. Hi, Dr. Smith-Whitley. That was just a really in-depth and amazing and helpful talk, and very much appreciated. And every time I keep coming up with a question for you, you answer it in the next sentence. So that's appreciated. One of the things that that I'm struck by here in California, where we can look at, from kind of a bird's eye view, a lot of different systems and a lot of different geographic areas, is in some of the areas in the state, healthcare is very fragmented, and we see that there are particular problems with transition in those areas. So, for instance, Los Angeles has many, many different health systems compared to other parts of the state where there are just a few that are talking internally. And so I wondered how, in that kind of a situation, if you had some recommendations for how to engage across healthcare systems and different types of providers, these adult providers who are going to be the sort of on the receiving end of this patient transition process, and bringing everyone to the table, and the insurers as well, bringing everyone to the table. It sounds like you've been really successful at that. How do you start that process? Was that something that came from you folks at CHOP? Also bringing your CBOs to the table, or what was that process like for you?
So we actually were really lucky. Again, I utilized the state. Mary Houlihan knows that, we have, through the Rush Project, developed a good working relationship with our state as far as how they foster the sickle cell program. And we have a state meeting of the sickle cell programs annually, and I kind of started hijacking the Philadelphia component of those meetings, and trying to then find our different partners, either in kind of like the mid-states of Lehigh Valley, Harrisburg, and really trying to pull those entities in, because one of the challenges that we have is very similar to yours. You get, like, I'm not exaggerating, 10 miles outside of our geographic area, and access dramatically changes. And so how do you pull those providers in that are scattered is something that we have tried to use state systems. I know Julie Cantor in South Carolina has tried to use a hub and spoke mechanism to get these providers together through a Project Echo type system. I think another way of doing it is developing some kind of way that they can actually utilize the pediatric or the adult centers in the city as a resource. So I use those connections because I have a college-based thing where we try to call the different providers in different areas where we know the kids are going to be coming to college, and actually setting up a working relationship so that they know they can call us if they have questions about sickle cell care and anything that's patient specific in their area. So it is incredibly a challenge because one, the numbers are scarce, the numbers of individuals per healthcare system or per provider as you go further out from these sickle cell centers. And so getting that provider to buy into anything, it's really got to be a good payoff for them. And usually the only carrot that we can hold is either something that is CME based or something that allows them access to a sickle cell expert almost 24/7.
Which does sound like a big challenge. Thank you very much.
It is a huge, and I think that, when I look at what California and Georgia are doing, I'm jealous. I mean, I think that, one, you all are doing relationship development in a different way from a stakeholder group perspective that is systems-based and community-based. And we have yet to duplicate that in the Commonwealth of Pennsylvania, and we're trying. But I think that through those kinds of systems, you can find different ways, either through telemedicine, telehealth, versus community health workers that go out as kind of like liaisons to these smaller communities and come back with information. I think all of these things could be solutions going forward, but you all have the capacity that we don't necessarily have of being able to see how healthcare utilization patterns change after you make these after you implement these changes. And so I really applaud what you all are doing, because I think you all will have a unique way of looking at what's happening to that young adult population that not all states have.
Very kind. Thank you very much. I think we have a couple of other questions that have come in.
Okay, I'm just going to do a time check. It's it's getting close to 12:30, but I think we'll just continue to take questions folks can, jump off as they need to, but we'll keep going if that's okay with you, Dr. Smith-Whitley.
Yeah. Absolutely.
One question is, what do you do if the patient is not ready to transition due to poor cognitive functioning or lack of education? However, the doctor wants them to transition.
Yeah, I definitely think that those are situations that are unique, and we try to make allowances for those. For individuals that have learning differences or cognitive differences, we have really kind of embodied what we do with our patient population here at CHOP with autism or with trisomy 21, and we allow a longer period for that transition process. And we are unique in that we have a team that, because of the complexities of care, we have a team at Penn that is particularly focused on providing care for individuals with neurocognitive deficits. And so we are really lucky in the sense that we have an adult-focused primary care team that's on the receiving end, and then we can then build the sickle cell expertise around that process.
Excellent. With so many providers in the area, how did you determine which to approach first? Did you base it off insurance billing?
That's a really good question. So I think that one of the things that we, at least at CHOP, wanted to support is that we really needed to foster programs with sickle cell expertise where the as broad a population as possible could go. And so to me, what the biggest thing has been is the challenges around insurance. And I really have a difficult time supporting programs that will not take Medicare, Medicaid type practices. So we have tried to stay true to those that provide care for the population that we serve. So we have our case mix down to the level we know who has which type of insurance and which programs are taking those types of insurance, and we tend to support the adult programs that provide care for all.
The next question is about institutional buy-in. How do you justify the care team to your institution? Did you do a cost analysis for each coordinator, social worker, nurse practitioner, et cetera, or did you do a presentation of the burden to key leadership?
So I did both. And one of the things in getting support from my community health workers and getting support from my behavioral health specialist, and through getting support for our transition team on the adult care side, we did look at a cost-based incentive and really showed that if you took care of this patient population well, then you might be able to avoid high-cost care settings and free up space for other revenue-generating services. And so we support a acute care unit. So we have a day hospital where we have beds where we can see patients and administer pain medications, and if they are not, if their pain is not manageable within a certain period of time, just take them into the inpatient side. And a similar system is developing at our Penn program. And so we did present objectives and goals to hospital leadership in order for them to buy into these programs. And so I present to them as well on a twice yearly basis.
Okay. So if anyone has another question related to the topic of transition, this is your last chance to send it in. Otherwise, we're going to wrap this up. I do want to thank everybody for joining this webinar. I want to thank you, Dr. Smith-Whitley, for this amazing presentation. And I did want to announce again that our next webinar on transition will be February 28th. We will be featuring the other PCORI grant on transition and have a few speakers from, where is it, Cincinnati? Where are they from? I forget where they're from.
Charlotte.
Charlotte? I guess you would know. Those are your cohort. So that'll be a really great presentation as well. You know, also I have put up the videos on sickle cell disease so that you can see the link to those. These are videos that are really kind of motivational, so really directed towards young adults at the beginning of the transition period to kind of help them think about their own responsibilities and their own decision making as they move forward in the process. So with that, thank you so much to everybody, and don't forget to like us on Facebook and visit our webpage, casicklecell.org.